Welcome to Women Mastering Midlife, where we dive deep into the rich complexities of womanhood in our middle years. I'm your host, Victoria Byrd, a pharmacist, certified women's health coach, and your guide on this transformative journey. Whether you're navigating perimenopause, thriving in menopause, or mastering midlife's many transitions, this is your weekly dose of expert guidance, compassionate support, and a judgment-free space to explore it all. Together, we will rewrite the narrative around this remarkable stage from being something to dread into a beautiful transition. On this episode of Women Mastering Midlife, I was very excited to welcome on the podcast nurse practitioner Kristen Stehle. She's a menopause specialist providing individualized modern menopause care. She is a certified Menopause Society practitioner. She has a practice in Connecticut, which you can find her on social media, sharing on women's wellness, on sexual health, and all things midlife. We had a great conversation around the genitourinary syndrome of menopause, GSM. We talked about sexual health and wellness, libido, midlife. We got a little bit off on a side trail about advocacy and some of the things that we see broken in the healthcare system, some from my pharmacy experience and some from her having a private practice. She gave some great resources to check out at your local library, or in my case, listen on Audible at the end. And I hope that you, by the end of it, feel empowered and educated to head to your doctor if you're having any symptoms of pain or discomfort, increased urinary tract infections, any kind of genitourinary issue while experiencing the menopause transition. So I hope you enjoy the episode. I hope you learn a lot. And maybe by the end of it, you'll be just as fired up as we were to see some change in women's healthcare. Thank you so much for joining me, Kristen. We are going to get into a conversation today that not a lot of people want to have. So I think it'll be hopefully informative and beneficial for women to listen, learn, and have some knowledge in their pocket of what's coming and what's happening in their bodies and what they can do about it. So thanks for coming.
Absolutely. Thank you for having me.
So can you share a bit first about your journey into menopause care and women's sexual health?
Yes. So I have been a nurse practitioner since 1997 and have been an OB-GYN for 20 years and then primary care for women for about 6 years. And during my practice, I was a new nurse practitioner in 2001, 2002, when Women's Health Initiative came out. And we had gotten some education, a little education in my nurse practitioner program on menopause and how to prescribe Prem-Pro, and very little, but we had a little bit. And when Women's Health Initiative announced the extreme higher risk of breast cancer and cardiovascular risk, my practice and myself, it was scary. And I remember exactly where I was. I worked in an out-of-hospital birth center in New York City, and the midwives and I were sitting around the table talking about it. And I immediately called my mom. I'm like, Mom, you have to get off Prem-Pro. It's going to give you breast cancer. So for many years after that, I had no option really for treating women who were having symptoms of menopause, hot flashes, night sweats, mood changes. And I felt at a loss for what I could do for women. And there were a couple of non-hormonal medications that we used, but, varying degrees of successfulness in terms of treating the symptoms. And it wasn't until a close friend of mine who started out as a patient about 15, 16 years ago, we became very friendly, and she was starting to have symptoms of menopause. And she was coming to me for primary care. She's like, Kristen, I need hormones. I need to feel better, and you need to figure this out. So, underneath my fear, I, started looking into things and had read more and had found that, the data that came out of Women's Health Initiative was very inflammatory and not necessarily true. And when you look at what they're saying about the 26% increased risk of breast cancer when taking hormone therapy, estrogen and progesterone, and a very specific type of hormones, the conjugated equine estrogen and synthetic progesterone, they had seen a 26% increase. When you actually look at the numbers with, in the grand scheme of things, out of 1,000 women, every year, 5 women will be diagnosed with breast cancer. And when you add this conjugated equine estrogen and progestin, you add one more case of non-fatal breast cancer. So when I looked at those numbers and looked at the actual study where they were, starting women who were in their 60s already, who could potentially have had some established heart disease, I became more comfortable with the fact that I might be able to prescribe hormone therapy, and looked into it even more and looked into the different options of the bioidentical hormones, the estradiol that we could give in transdermal form that bypassed pass liver metabolism, and the oral micronized progesterone that was the same molecular structure as the progesterone released from our ovaries. I became more comfortable. And I absolutely wanted to help my friend, and realized there were questions that I wasn't asking my patients because I really didn't even know how to help them if they had said that they had these problems, that they had these symptoms. So that's kind of where it began. And then it kind of rolled into my own perimenopause journey where I was feeling like, okay, I'm having some night sweats. I'm having these really horrible mood fluctuations. And, what's the root cause of these? Or is it the fluctuations of hormones that are causing this too? So it kind of became very important very quickly for me to figure this out. And I had some very close friends who were doing some hormone therapy themselves. So that kind of began the investigation for me.
Yeah, I think it's funny when you have a client base or a patient base and they're experiencing something, it's one thing, but when you start to experience it yourself, it's another.
It brings a whole new perspective.
Yeah, I'm not saying that men can't advocate for women's health, but until you've experienced the symptoms of menopause, you just be quiet.
Yes, definitely.
So we're going to talk specifically today about sexual wellness in midlife. And we're going to dig into a little bit of GSM, which is the genitourinary syndrome of menopause, what that is, what that umbrella covers, and how women experience these changes and what we can do as women and providers to care for them. So for women in midlife, how would you define sexual wellness? What should we prioritize as our bodies and lives change?
So I've been thinking a lot about this, and sexual wellness, I think, is very individual and very, very personal. And it can absolutely impact many different aspects of our lives, how we feel about ourselves, how we feel about our relationship with our partner, how we feel about ourselves in terms of how we're aging. And I think when we look at the media and look at what is presented to us, a lot of what's presented to us is that women in midlife start to really not have a sexuality. And I think that's confusing. And that is, for most of us, or for some of us who feel still like our sexual lives are important to us and something that we want to have be a really good part of our lives. When we see that in the media and then we start experiencing symptoms of vaginal dryness or pain with intercourse or lack of desire, low libido, it becomes kind of a kind of scary situation where we are feeling less than and less about ourselves. So sexuality, I think, is very individual for each and every person and something that is important to quite a lot of people.
I agree. And I think as far as what we see in media, it's almost that our sexuality is tied to reproduction. Mm-hmm. And when we're no longer reproducing, we just shouldn't worry about sexuality. And that's very frustrating.
Mm-hmm. Absolutely. And I think that is a message that some women get from their practitioners and their medical providers, that, if they're not being asked about how their libido is, if they're not being asked if they're satisfied with their sex life, if they're not being asked if they're having pain with intercourse or vaginal dryness or discomfort, then it kind of speaks to that idea that it's not important.
Yeah. We need to start changing our checkup forms that we fill out online. I mean, we answer like 1,000 questions every year before our annual visits. And it wouldn't be hard to add a couple of them asking about.
Yeah,
just a couple. So a lot of things we're seeing about these symptoms in menopause, their title, it's called GSM for a lot of people who don't know what that means. What is GSM so that we can kind of help women understand it that aren't in the medical community?
Okay. So GSM is genitourinary syndrome of menopause. And the name or the diagnosis was changed a few years ago from vaginal atrophy. And previous to that, it was called senile vagina. So it's been changed to kind of encompass the full scope of what we're actually talking about with the diagnosis. And that it encompasses both the vagina and the vulva and the urethra and the bladder. So all of the tissue that comprises the vagina and the vulva and the urethra and the bladder are embryologically the same. And that tissue has estrogen and androgen receptors there. And as we become menopausal, as we go through perimenopause and after our final menstrual period, when estrogen has declined down to basically zero, and testosterone and DHEA has also declined, the stimulation of that tissue is very low. And we're seeing a decrease in vaginal moisture and in moisture of the tissue, a change in the turgor of the tissue, a change in the elasticity, and more of a sensitivity there. So those changes can result in some discomfort, some dryness sensation, some itching, some pain with intercourse or discomfort with intercourse, but it can also cause some urinary symptoms, like some urge symptoms, feeling like that you have to go to the bathroom all of the time, or waking up in the middle of the night to go to the bathroom frequently, or symptoms like leaking and dribbling.
Okay. And then also, I've heard that it can also increase your risk of UTIs. Is that?
Yes, absolutely. Absolutely. Because of how the pH of the vagina changes and the more susceptibility to microorganisms, that can absolutely happen.
So it's far more encompassing than a senile vagina.
Yes. Yeah.
I've never heard that one before. I've heard atrophy, and it makes me sad, but I've never heard that one.
Senile vagina. Add that to the list.
Goodness gracious. So we talked a little bit about what physiologically happens, and we talked about the pain and discomfort. So I've also heard from women that even something as simple as going to the bathroom and using tissue paper when they wipe can be really uncomfortable. So it doesn't even necessarily need to be around sexual intercourse or any kind of sexual encounter, but it actually can affect your daily life, what kind of clothes you wear and those kind of things.
Absolutely. And I've seen people in my practice in the office women who feel like, I definitely have a yeast infection. I have such bothersome itching and discomfort. And when we look and when we test, there's no yeast, there's no bacteria, there's no signs of any other dermatologic issue. It's more just a reactivity to the lack of estrogen.
Okay. And so in treating that, if someone is comfortable with using hormone therapy and it's not contraindicated, which, I mean, back up a little bit. If you're using vaginal estrogen, the contraindications for vaginal estrogen are different than other estrogens. So would you like to talk a little bit about how you would go about treating GSM?
Sure. If a woman were just solely complaining of vaginal symptoms, then we have the opportunity to just treat very locally at the vaginal and mucosa level. And we can treat that with a topical. There many different options. There's a topical estrogen, which we can provide in the form of a vaginal cream or a vaginal tablet called Uvafem. The vaginal cream, there's Estrace, or there's a Premarin cream, and one is estradiol and one is a different type of estrogen. So the tablet, there is a soft gel suppository that's very nice called Amvexi. And there is also a vaginal ring called the S-string that is similar to like the NuvaRing for contraception, only just providing localized estrogen. And that is a ring that you can put in and leave in for 3 months and not have to think about it. The other medications, the Estrace or the vaginal cream and the tablet, are used initially every day for 2 weeks and then twice a week to kind of maintain. The Vexi suppository, that's used daily.
So for women who are concerned, I mean, we've talked about the WHI study, the statistics being a little skewed for who we're treating these days, but the safety profile of using local estrogen versus the transdermal for whole body symptoms is different, correct?
Absolutely. So with local vaginal estrogen, there's very little, if any, systemic absorption into the systemic circulation. So women who have a history of breast cancer, women who have a history of blood clots or hypercoagulability, where they could potentially have a blood clot more easily. These women who might be at higher risk for taking something systemic, a systemic hormone therapy, can absolutely take and use a vaginal estrogen.
So we've talked about what it is, and we've talked about how to treat it, but then there's parts of your libido decreasing that come with midlife that's not necessarily just treated or the need to treat with estrogen cream or the physiological symptoms. There's also some psychological factors that contribute to the decreased libido during menopause. Could we talk a little bit about that?
Absolutely. But I just want to mention that there are some other treatment options besides just estrogen. So in addition to estrogen, there is also a vaginal DHEA, prasterone, which is called Intrarosa, which is a daily suppository that converts locally to estrogen at the tissue level and testosterone at the tissue level. There are also some non-hormonal treatment options that help to provide some comfort. There's vaginal moisturizers and vaginal lubricants that can be used either during intercourse, the vaginal lubricants, or the vaginal moisturizers can be used multiple times a week to give some relief if you don't want to use hormones. And then there's also some women I've seen that have very significant symptoms of diminished estrogen from the vaginal mucosa and a very, very narrow vaginal opening. We may need to support them with some testosterone too. And currently there's not an FDA product that we can use vaginally, but we can compound estrogen, estradiol, and testosterone together. So lastly, in terms of non-hormonal treatments, there are a couple of lasers that have been developed to improve collagen production at the vaginal mucosa level. One is called the Mona Lisa and one is called the Diva laser. And they both have shown really good, very effective, good results with the use of those lasers on an annual basis.
That's fascinating. It's nice to know that there's options outside of just estrogen replacement.
Absolutely. It's, the more options that we have, nothing is one size fits all. So we need to really align our treatment with what the goals and values of our patient are.
Absolutely. So when we talked about the question of the psychological factors that contribute to your decreased libido during menopause, what are some things that you see in women aside from just the physical discomfort of menopause as far as libido is concerned?
Mm-hmm. In terms of libido and in terms of pain with intercourse, I'm thinking of a patient who came to me because of this, and we started her on some estradiol, and that's helping. But she came back to me saying that it really has impacted how she views herself, that she was seeing herself as being less sexual, less attractive. She had, really had expressed that she had a great has a great relationship with her husband, and he's very, very accepting and, very, what am I trying to say? That he's very supportive, and he has really kind of, taken a back seat and let her drive. But she's feeling like the fact that he's giving her that space means that he's not attracted to her anymore.
Are you standing in front of your mirror, barely recognizing the woman looking back at you? Perhaps you're lying awake at 3 a.m., body betraying you with another hot flash or night sweat, wondering if this is just how life has to be now. As a pharmacist and women's health coach, I've walked this path, both personally and alongside hundreds of women just like you. That's why I've created 2 powerful ways to reclaim your midlife journey: the Women Mastering Midlife community and personalized one-on-one coaching. In our community, you'll find your tribe, women who understand exactly what you're experiencing. Together, we'll navigate perimenopause and menopause with evidence-based strategies, twice monthly group coaching sessions, and a judgment-free space to share your story. But if you're craving deeper, personalized support, my one-on-one coaching program offers dedicated guidance tailored specifically to your body, your symptoms, and your life circumstances. No more Googling at midnight, no more trial and error with miracle solutions that leave you frustrated and depleted. Are you ready to transform your midlife experience? Book a free discovery call with me today. You will find the link to schedule in the show notes or check out www.womenmasteringmidlifecoaching.com for more information. In just 15 minutes, we'll explore whether community membership or one-on-one coaching aligns best with your needs, because you deserve to do more than just survive this transition. You deserve to thrive. Join us in aging boldly, beautifully, and on our own terms.
So it has really impacted her feeling about her sense of self. And I see this echoed, in a lot of my patients, that, it really impacts how they view themselves and their relationship with their partner.
So in talking about partners is actually leading into more questions for me. Mm-hmm. So how can women navigate conversations about the changing sexual dynamics with their partners? Because they don't understand what's going on with our bodies or our minds or our hormones. So how can we have those conversations, especially for some of us who don't really talk very openly about sex with our partner? How do we navigate this?
I think, reading books like Dr. Kelly Kasperson's You Are Not Broken and Jill Crapp's When Sex Hurts, 2 really amazing resources for practitioners and for medical women. Reading those books and sharing them with, and kind of getting the knowledge yourself and listening to podcasts like this and knowing the physiology and knowing the why, and then being able to share that with your partner, and, kind of starting off with just very benign kind of statements like, hey, there have been some changes that I've been noticing in my body, and I want to share what's going on with you so that you can understand how I'm feeling when we are being intimate with each other and trying to, have a sexual encounter, so that we can kind of avert any discomfort and kind of make it as pleasurable as possible.
Yeah. And I think as I was listening to you, I think a lot of women also, it's so multifactorial, because you have the weight gain and you have, the hormones are all over the place, but you've also, I know when I started recognizing that my reproductive system was starting to decline, that my ability to procreate was a grief I had to deal with, that was coming to an end. And so there's so many things that we are internalizing and maybe not sharing with our partners as well, that decrease our desire overall, aside from just the physiologic and the discomfort that might come with intercourse.
Absolutely. And the female arousal is so different than male arousal. So to be able to kind of point that out and explain that to your partner, if your partner's male, then that can be helpful. And a lot of times men, despite the fact that they've had a bad day, someone cut them off in line at the grocery store, the kids are going crazy, they can just, snap to attention. Where women, it takes a little bit longer to get things moving and to become aroused. And if we're expecting it not to be pleasurable, or if we're expecting it to be painful, then that can even dampen and squash our libido.
Yeah. It's unfair sometimes, I tell you. And so there's a lot of things that are going on in our minds that I keep telling women, give yourself grace when you're handling all of these life changes and transitions. So what role does self-compassion play in addressing sexual health changes and challenges?
I think it's huge. I think if we're beating ourselves up over not feeling sexy and not feeling great in our bodies, and we can't sleep because we're having hot flashes and night sweats in the middle of the night, so we're feeling fatigued, and vaginally we have discomfort, then, how can you not feel not great about yourself? So really kind of giving yourself some grace and saying, okay, this is my state right now. And if I desire to work on this and get some help from a certified menopause practitioner, and maybe explore some either hormonal or non-hormonal treatment options, then, that's going to take a little time to kind of get that in there and get that working. But these are all options that we have. So you're not in a dead end situation, and this isn't the way that it has to be for the rest of your life.
Yeah. I mean, some of the things I've seen on media is that we literally internally shrivel up and die. And that's not the way that it needs to be in midlife. That's
not the way that it needs to be. And that's not the way that I want it to be.
No. So I've also noticed that there's a shift a little bit we were talking earlier about social media and how our generation, our midlife women, are taking it by storm and using it for advocacy and education and empowering and also connection and positive. It's a positive place. But I feel like in medicine, there's still, even though there's pushing at the hill for more women's research, and, we are on the cusp of it, it's not going to happen overnight. And I feel like sexual health is really overlooked. Like menopause is overlooked in general, but the sexual health in menopause is even more overlooked. Why do you think that is? And what can we do to fix this?
Well, yeah, no, I think you're so right. Men have had options for erectile dysfunction for many, many years. And it was only within the past 10 years that Addie was developed, flibanserin, as a medication for low sex drive, low libido. I think that was maybe only 8 years ago now. And then Vyleesi, bremelanotide, an injectable form of medication. And those are basically only 2 FDA approved medications for low libido for women. So when you look at the amount of research that is, and the amount of money and funding for research into erectile dysfunction and syndromes that are afflicted, men are afflicted by, it's so much more than for what's been given, so much more than the amount of money that's been given to the funding of studies for women. So that absolutely has to change. And I think the more that we can be vocal with our own practitioners and with our own insurance companies to cover medications like these, and the more that we can pressure our state representatives to fund women's health and to fund menopause care and to fund sexual health for women, the more that we're going to see some benefit there.
I was thinking about when you were talking about all the money and research. I remember, so I've been working in pharmacy since I was in high school. So since 96. So I remember Prozac coming to market. I remember Viagra coming to market, and then Cialis. I remember all those. It's almost like milestones in my brain.
Yeah. Yeah.
And I remember the commercial of the man and the woman in 2 claw bathtubs on top of a mountain holding hands separately in their own bathtubs. And I was thinking to myself, the amount of money that's gone into market this is amazing, let alone the research. And I remember long ago, back when those medicines first came out, the insurance companies, I never had to get a prior authorization from an insurance company to cover it. They might say you could only have 5 tablets a month. But then now that I'm this age, I'm thinking 5 times a month is like, that's good.
Right.
That's plenty.
So now we have those 2 medications, but we are basically off label using testosterone gel for women to help with libido. And this is first line therapy on the Menopause Society's guidelines for treatment of hypoactive sexual desire disorder, which is the diagnosis, as well as ISSWSH, which is International Society of the Study of Women's Sexual Health. So we're using this controlled substance off label to treat women, and we're doing it very safely, but we are still jumping through hoops to get our local pharmacist to actually give this to our patient because some have not been educated or received the education or have read the studies where this is indicated for women and it's not just a male hormone. And the fact that it's a controlled substance. So are we able to split up the box? It comes in, the T-stim gel comes in a box of 30. So are we able to split up a box, which basically would last a woman basically 10 months because we're giving 1/10 of a dose of a male dose. So, what's the pharmacist supposed to do where they're only supposed to give a 3-month supply of a controlled substance, yet they're not supposed to break up this box. So there are so many hoops that we need to jump through, even for this medication that we can use very safely. And we are able to use this off label. That's completely within our prescribing rights, yet it's still something that our women really need to suffer with, that they can't get their medication.
Yeah. And I think it's even harder way back in the dinosaur age when I was practicing pharmacy. We didn't have as many restrictions on controlled substances as they do now because there just wasn't the opioid crisis that there is right now. And I actually worked in a pharmacy. I managed a pharmacy near a pain clinic. So the amount of methadone and fentanyl that came flying off of our shelves. But I feel like now with even tighter restrictions on controlled substances, you're tying the hands of pharmacists. So we had no education about menopause. It might have been, I was talking to somebody else about this, that, when we did therapeutics, we would get a patient with all their meds and they might be on hormone therapy, or it might tell us the day of their last menstrual period, but it was never an actual disease state that we learned about and covered and managed. It was just kind of a side note. And so we didn't really know a lot about it. And then in the middle of school, we had the WHI come out. And so then everything just started collecting dust. And then with controlled substances, those started getting tighter and tighter. So we're not educated. We have these restrictions on us. And then the patients who are nervous about finally talking to their care provider about this, they get their prescription. They're so excited that they might finally have some relief and and have this increase in libido and things that they've been hoping for. They finally get the nerve to talk about it. Then they get to the pharmacy and the pharmacist's hands are tied because they can't dispense it. Right. And some of them are not educated in why it's being used or how it's being used. Right. And it's still there's still no indication. So we get all sorts of warnings that we shouldn't dispense this.
Yeah. And you're trying to practice safely.
Yes.
And you're trying not to cause any harm to your patient standing in front of you. So there needs to be some really clear direction from somebody. And there needs to be a loosening of this particular restriction so that women can actually use this medication, this hormone that might be beneficial to them.
Yeah. Well, and I try to think on why testosterone is controlled.
The doping scandal, right? From the 80s. Yeah.
And the steroids that people are using for those kind of things, you're more likely to find them in the back of a trunk at a gym or a locker room. They're still getting them. Anabolic steroids are still available and they're still getting them. And so it's just frustrating. It's similar to when the state of Oregon decided to make Sudafed a controlled substance.
Yeah.
It's Okay. So now I need a prescription. I can't even just go to the counter and get a box behind the counter. I now need a prescription from a doctor because I have a stuffy nose. This is kind of similar to me. And I start to get on my pharmacy soapbox of like, can we really, like FDA?
Please.
What are we doing? That and the black box warning on vaginal estrogen.
Absolutely. Yeah. That needs to come off. That can't be universal on every estradiol product. You need to take it off vaginal estrogen.
Yeah. And if everybody were to read every packet of the required drug pamphlets that come with bottles of drugs, if patients were to read those clinical little things that fold out attached to every bottle, you'd be terrified. You'd never take anything.
You would never take a Tylenol.
No. So we all just like, it gets me so angry. I'm getting fired up now. Because I've seen comments. I'm in a lot of menopause groups, and I've seen comments from women who do go to the pharmacy and they feel judged and they feel criticized, or they've been told they can't get it. And then this slew of comments of like, why is it the pharmacist's job to tell the doctor no? And, and then there's just this constant battle between all the different facets of healthcare. And I feel like we need to all come together to be able to provide care. And it's not going to happen in the construct that we have right now.
No.
So we need to figure something out.
Right. No. I'm very lucky. I have patients that are very local to me. I practice telemed in the state of Connecticut, but a lot of my current patients come from my previous OB-GYN practice, and I've lived in this community for a while. So most of the prescriptions are going into my local pharmacies. And initially I got some pushback, but then have, talked on the phone and visited them and given them studies. And it's been, the past couple of months have been really great. Me and my local pharmacists have been working quite nicely together.
Wonderful.
Yeah.
I think gone are the days, because we used to have those days when we would have relationships with the local pharmacies and the doctors. And we need to go back to that, especially because for all of the standards of care and all of the flow charts to follow when prescribing medications, I feel like menopause is completely off the chart. It's so individualized and everybody has a different experience that you can't just take, blood pressure is this level, we should start with hydrochlorothiazide at this dose. And, there's standards of care for a lot of diseases, but menopause isn't a disease. So we need to change this. Now it's becoming an advocacy for women's health episode.
Yes, I love it. I love it.
We veered off of DSM and now we're talking about changing the FDA and policies. I also think that insurance companies, they could loosen their reins a little bit.
It's a whole other, conversation. Yeah, there is so much there that insurance companies, I'll just say it, they're not trying to keep people healthy. They're, not trying to, they're not funding and they're not supporting prevention as much as they should.
Yeah. So, well, and I've had this conversation with my husband because he's in medicine, and I've asked him, think about how much of that end of life care money is spent on, and how if we worked on prevention, if we worked on nutrition, we worked on lifestyle modifications, we could get people off of medications, we could increase longevity and health span, not just lifespan. And it would end up saving insurance companies in the long run. But he was like, well, if you think about it from a practical standpoint, when people change jobs, if you're in your 20s and you're working for this company and you get this insurance and they spend all this money helping you prevent disease, and then you've changed jobs or you go to a different insurance company, they reap the benefit of all the money that another insurance company has spent on end of life. So it's all, there's a bottom line at the end of the day.
Interesting.
It's all about the bottom line if you think about it.
It is. You have to, to figure out exactly why this is happening, you have to follow the money.
Yep. Well, and for insurance companies to pay for testosterone, I noticed back in the day when I was working in a pharmacy that the directions would have to say, like, use this amount and discard the rest of the tube, which is also very wasteful. So if women don't follow the directions and keep the tubes, then they last them a very long time, which is great. But then if they do discard them, you're wasting all this medicine.
90% of your medication that you could use. Yeah. No, I know. It's crazy. It's crazy.
And I think there's a product in Australia for women.
Mm-hmm.
So the research is there.
It's there, and they are progressive enough to have approved that. And, we could be saving money, and we could be satisfying, half of our population and making lives better. And yeah, no, it's crazy.
I think yeah. And I think that as we age, we're more vocal than our mothers and our grandmothers about our demand for better healthcare. And so hopefully the drug companies will see that, because all these other companies are noticing that they can make money off of us, selling us, we're all desperate for relief and symptom mitigation and answers to our prayers. And so we'll buy the supplement, the product, whatever that claims they'll cure it all. So if we could, if we could get to a point where drug manufacturers are like, hey, this is actually a demographic that'll really buy testosterone from us, then maybe we can get them to make it for us.
Some money here. Absolutely.
So now that we've I'm sorry, I'm taking you on a rabbit trail of advocacy.
No, that's okay. I love it. I love having these conversations, and I love talking menopause and helping women to make their lives what they want and make them better. So this is fantastic.
Yeah. And I feel like we need to advocate for ourselves, because right now there's not that many people that are going to do it for us. And so in order to advocate, you have to educate yourself. So we're providing the knowledge and tools. So on that note, are there resources or books aside from, because you talked about Kelly Casperson and then you talked about another book, so you could say those again, but are there books and tools and resources that you recommend for women who've listened to our conversation and they want to help mitigate their symptoms? These
are the books that I would highly recommend. This is Kelly Casperson's You Are Not Broken. And she talks a lot. She's a urologist in the Pacific Northwest, and she talks a lot about testosterone in here. And as you can tell by the title, very empowering and very, very much to give the non-medical person information about vaginal health and GSM and libido. So excellent resource. And then this is an amazing book written by Andrew Goldstein and a few others. Jill Krapf is also on the list of authors. When Sex Hurts, also written for practitioners and for non-medical people. And Jill Krapf is excellent. Both Kelly Casperson and Jill Krapf, excellent Instagram, accounts that they're posting really evidence-based knowledge and research on GSM and pelvic pain and vaginal health. And then menopause resources in general. Estrogen Matters is an amazing book. Everybody needs to read this. And it's written by Avram Blooming and Carol Tarvis. And Avram Blooming is an oncologist, and his wife had breast cancer. And it kind of details their journey in estrogen hormone therapy for her post breast cancer, and talks a lot about the risks and benefits of estrogen and how it would impact breast cancer risk.
Yeah. And then, I think he did a great job in that book explaining what was wrong with the WHI as well. Yeah, I think there was a great section in that book. I highly suggest it to the women that I talk to that are fearful of estrogen, just to, whether you decide after reading it that you want estrogen or not on board. I think it's good to educate yourself with it.
Great. Yeah. Amazing book. And then Mary Claire Haver's The New Menopause. I know a lot of women who have come to me from seeing her on Instagram and reading her book. And it's a very easy read and empowering read. And kind of to start, if that's the first book you read, that's a great one, because it's a nice all-encompassing taste of the information that's available today.
Yeah, she's done a lot of footwork in this realm, and I think I read her book, and I've followed her the Galveston diet era, and even before that, and so I've watched the evolution of her advocacy for women, and she's done the footwork. She's in the trenches. And so I definitely recommend her book as well.
Yeah.
I haven't read the other two. Kelly Casperson's, she revised it. It was a little updated. It's either, I don't think it's here. I think it's over there. But it's in my stack of things to be read. I'm more of an Audible.
Yeah.
with all the driving I do, it's so much easier to listen. But some books you just need to look at. And I feel like I want to look at her book. So that's on my list of, it's a beach read.
Definitely. You'll start some conversations on the beach too.
I know. When you're in the menopause realm, and you're reading things like You Are Not Broken and Why Sex Hurts on the Beach.
Oh, I know. I had my When Sex Hurts out on the plane. I was like, okay, hi. Yeah.
But I think just breaking down the barriers around the conversation. And I think women understanding that they have the right to sexual health and sexual wellness in any way, shape, or form that they want it. I think that is something that women can really benefit from. And as a takeaway, I think we've told them, like, advocate for yourself, and it's okay to want this.
Yeah.
And it's also okay to have boundaries around it. Like, this isn't something that's important to me, but this is important to me. And talking to your partner, really opening the dialogue and having those conversations.
Absolutely. And I didn't say that, at times I ask women about their libido and they say, okay, it's really low. And my next question is, does that bother you? And for some women, they're like, yeah, not really. I don't have a partner right now, or my partner has erectile dysfunction and is untreated. So we find other ways to be intimate with each other, or we're not at all, and it's fine.
Yeah. Yeah. And that's okay too.
Absolutely. Very individual.
Yeah. And it's our time to decide what we want. We've given ourselves for so long to other people that this stage of life, it's about us.
Absolutely.
So thank you so much for coming on. And it's been really informative. I learned a lot today, and I hope our listeners do too. And I will put in the show notes ways to find Kristen on social media. And she's in Connecticut, but she's sharing her knowledge across the world with her social platforms. So be sure to give her a follow.
Thank you so much, Victoria. This was really fun. Thanks so much.
Good. Thank you for coming.
All right. Take care.
Thank you for tuning in to this episode of Women Mastering Midlife. If this episode resonated with you, share it with a friend who might need to hear it. And remember, small changes can make a big difference. We will be back next week for another episode of Women Mastering Midlife. Until then, find us on Instagram at Women Mastering Midlife or my Instagram account, Miss Victoria Byrd, and join us in the Women Mastering Midlife community to share and continue our discussions. We'd love to hear from you. Please rate and review the podcast to help us reach more women mastering midlife just like you. You'll find links to what you've learned here today, as well as ways to connect with us in the show notes below.